I suppose it's good afternoon, everyone, at this moment. It's a moment of great honor and privilege for me to extend a warm welcome to all of you today to the localized webinar Malaysia, organized by APELS, Asia Pacific Endo-Lap Surgery Group. We received 425 registrations to this Zoom webinar today from surgeons and medical professionals over Malaysia and in many parts of the world. As a medical academic group, APEL has been organizing various types of physical training, workshops, and virtual events in Asia Pacific region in the past 6 years that inspired many surgeons and medical professionals in the industry. We are now emerging in a new era. I'm delighted to see the host of this event, Professor Abdul Gafoor Mubarak, has been making extremely great effort to organize this localized webinar focusing on the topic of colorectal endo-lap surgery, new technologies, and troubleshooting complications. This event capitalizes our strength and realizes a commitment to you to cultivate an intensive learning culture, enhance professional competency in endo-lap surgery to meet the ever-challenging in today's clinical arena. The 2.5-hour webinar will capture the essence from our APELS legendary workshop with the presence of some most noted speakers from Malaysia and other Asia Pacific countries, Professor William Chen, Taiwan, Professor Joe Neroy from Vietnam, Professor G.V. Rao from India, Dr. Vimal Kumar Vasudeavan and Dr. Zenga Perumal from Malaysia to share about colorectal endo-lap surgery. We're honored to have Dr. Paul Selvindoss, also Malaysia, to be our moderator of this event. We appreciate his contribution to organize the webinar with Dr. Abdul Gafoor Mubarak together. We are honored to have SELSMA Malaysia, Society of Endo-Laparoscopic Surgery in Malaysia, as our local event partner. Thank you, Dr. Vimal Kumar, President of the SELSMA Malaysia, and the team for standing by our side in the great endeavor of promoting endo-lap surgery to meet the ever challenges in today's clinical area. As the chairman of APELS, I look forward to the rapid growth of the society and wholeheartedly commitment to educate, train, and innovate in every aspect of endo-laparoscopic surgery. Once again, I welcome you all and sincerely hope that you will enjoy the program. I look forward to seeing you all in the coming training workshops, both online and in person. Thank you.
Thank you, Professor Lee. I think maybe I can start the ball rolling. And hi, everyone. My name is Gafoor, and I will be the host for today's webinar, focusing on colorectal endo-lap surgery, new technologies, and troubleshooting complications. I will be joined by Dr. Paul Selvindoss, who will help me to moderate this session. So before I carry on, maybe Dr. Paul Selvindoss, you can say a few words, and then I can start the ball rolling with our eminent speakers.
Yeah, hey, thanks, Gafoor, and hi to everyone. We've got an exciting program, as Dr. Michael Lee had just said, and I think we'll get straight to it, Gafoor, so that I think the participants want to hear what's new in laparoendoscopic surgery in colorectal surgery.
Great.
Gafoor, back to you.
Thanks, Paul. So actually, when Malaysia managed to get a localized, a local webinar from APELS, it was a very big honor for us, especially when we were given this opportunity to host. And it became even more meaningful when we could engage SELSMA as the local partner, and it shows our continuous endeavor to provide training as well as teachings, even though we are faced with this ever challenging pandemic that is going on. In fact, in Malaysia, we recorded the highest number of cases today at 8,400 or 8,600 positive patients today. But it doesn't stop us from disseminating knowledge as well as improving our skills and our ability to learn more about surgery. So we have a list of eminent speakers, and Professor Lee has already has already mentioned who they are, and I'm very thankful to everyone, especially our international speakers, Professor William Chen, whom I spent some time with, and I'm very close to Professor G.V. Rao and Professor Joel Leroy, and also our local speakers, Dr. Sankar Perumal and Dr. Vimal Vasudeavan. So I think before we start, we have a poll. So maybe we can kick off the session with a poll for everyone, I think except the panelists. So maybe we can put it up and then we can do it. All right. So you have a few questions here. The first two would be, all you have to do is just choose one and then subsequently submit, and we will have the results immediately. So you can choose to answer now. If we have the result, maybe we can just put it up immediately and it'll be interesting to see what the results are like. Do we have the results? Right. So I guess it is a very well-balanced source of reference for APELS. Where did you hear it from? Most of us heard it from either APELS Facebook or from SELSMA's Facebook. And the reason why and what are your expectations in joining APELS Live is same as me, to learn about latest technology and skills. Great. Next poll question.
That's it.
That's it. Oh, great. I thought we had more. Okay, so let me kick off the session by inviting our first speaker, none other than Professor Michael Lee. And Professor Michael Lee is someone that is not a stranger to Malaysia at all. He has been visiting us for many, many years, and he's a close friend to a lot of surgeons in Malaysia, and he has helped many of us develop ourselves and develop our societies as well. And he is the Honorary Consultant General Surgery Director of Minimal Invasive and Robotic Surgery Development in the Hong Kong Sanatorium and Hospital in Hong Kong. And he holds honorary advisor positions in various other hospitals, including the CUHK Jockey Club Minimal Invasive Surgical Skills Center in the Prince of Wales Hospital in Hong Kong, and is also an honorary clinical associate professor in various places, including the Department of Surgery, Prince of Wales Hospital, Faculty of Medicine, the Chinese University of Hong Kong in Hong Kong. And his topic today will be Endo-Lap OR. It gives me great pleasure to introduce and welcome Professor Lee to give his talk. Please, sir.
Oh, thank you very much, Gafoor. I appreciate the introduction. I must make sure next time they give you a shorter CV so that we won't spend too much time doing it.
Okay.
So my brief today is really to tell you about Endo-Lap OR, which is obviously very close to my heart and close to the APELS objective. Minimum exec surgery is a dream. As long ago as Hippocrates' time, making a small incision has been a surgeon dream for thousands of years. And funny enough, Ronald Mavic had a idea or concept that surgical technique will be more or less be combined technique in the future. And that's a foresight. When we talk about minimal exec surgery, we don't just think about laparoscopic surgery. I think you should talk about endoscopic surgery, because this is also a technique where you don't have to open up the abdomen and perform surgery. In endoluminal surgery, really gone are days when we have to open up for ulcer bleeding as a laparotomy. I think 99% of the time we can stop it with an interventional technique, from adrenaline injection to heated probe to various other methods. Polypoid growth can be taken away with a EMR or ESD. Of course, we don't have to deal with difficult cholangitis with laparotomy, multiple incision the patient had before, particular cases of recurrent pyogenic cholangitis. This can be dealt with by our ERCP technique. And of course, you know, if you've got an obstruction, you can bypass it with a stent nowadays, and it's totally feasible. And why did I say that? Well, because we actually, in my previous hospital, produced the first randomized trial of the endo-laparoscopic approach of obstructing colorectal cancer. First world paper. And basically, we show that the colonic stenting can temporarily relieve the acute obstruction and then allow the patient to enjoy benefit of MIS resection later and avoid the creation of permanent stoma. This is a real demonstration endo-laparoscopic technique. But of course, various technique had its own limitation, both laparoscope by itself and endoscope by itself. So why not combine the two procedures together? Wouldn't it benefit bigger arena of our patients' load? As you can see here, we have pictures of showing upper GI work, lower GI work, all combined with the endoscope. On the left-hand side, you can see an intraoperative ERCP for CBD stone, or you can do a endo-lap colorectal resection at the bottom picture. And of course, at the top, you can see an endo-lap resection of a upper GI tumor. How does this come about? Well, the idea of endo-laparoscopic surgery plus laparoscopic surgery create this concept endo-lap approach. And the concept endo-lap approach need to be done at a place where it is convenient. It is not cumbersome. So we had the idea back in 2005, that's already 15 years ago, about creating an environment where it's friendly for both surgeon and endoscopy. This is a traditional laparoscopic operating theater. But this is the first endo-lap OR built in Asia in 2005. And I'm proud to say it's probably the first design in the world at that time. And that is ideally having an endo-lap OR with two systems, which is interchangeable between endoscope and laparoscope with energy sources. So this is one beyond a laparoscopic theater, it's an endo-lap theater. And this is the concept of endo-lap OR after successful use of the 2005 endo-lap OR. We expanded the concept to include robot because robot is an MIS instrument. So we created an environment where both endo-laparoscopic work and robotic work can be carried on in the same environment. And this is not, this is reality. In fact, this concept came up back in 2008, 2008, and it came into action in 2009. So that's been in existence for over 12 years now. So with the availability of both equipment in the same operating theater, really an easy operating theater setup is allow us to perform both procedures. No need for really bulky equipment, no need equipment connection, reconnection, extra theater setup. We actually produced a paper on the first endo-lap OR. This is show the reduction in workload, the efficiency of having an endo-lap OR. So integrated OT for MAS, we call it endo-lap OR, making it easier for surgeons. simpler for the operating room staff, safer and better for the patient. Of course, with the new tools, we have an OR that include the robot as well. This is the final design of the robotic endo-lap OR. I just realized I had the two video reverse. The first video should be this one of the endo-lap OR. I've shown the second video of the robotic endo-lap OR first. I apologize for that. So this is really become a very popular design, and in fact, back in Hong Kong, the endo-lap OR is available in all the public hospitals and the private hospitals. What about the robot? Well, I think with the addition of the 3D imaging software, it enables us to do even finer operation. And I think the urologists will agree that they would not do a prostatectomy without a robotic assistance. And of course, for general surgery, I can see many areas application where anastomosis, fine anastomosis is concerned, then the robot is absolutely beneficial to your practice of that surgery. And this is how it was in action in old hospital when we had the laparoscopic robotic available for cancer of the rectum operation. These are just how the OT was designed and the mechanism of control. And this is the endo-lap OR, the robotic endo-lap OR in actual usage. All control are finger-friendly, accessible easily. Including the docking of the robot is easy because there's enough room to do all this. So, integrated operating OR, the goal is to provide the best environment for surgery and operating team. Working conditions are improved without the sacrifice of safety, efficiency, and comfort. The ultimate aim is to deliver better service to patient, improve outcome. So my motto is continue to innovate, develop, and discover new frontiers to improve our patients' care. Thank you for your attention.
Thank you, Professor Lee. Very interesting. In 2005, in January, I haven't even started being a doctor yet, you know. And I didn't even understand the concept of endo rather than endo-lap OR, which tells you. And I'm glad that, you know, it's great to hear that it's been there for so long, and, you know, it's great to hear that we have these technologies that are able to innovate and help us to deliver better services to our patients. We have a few questions, but I think we will leave it till the end of the session. I will introduce the next speaker. The next speaker is Professor William Chen, who is no stranger to Malaysia as well. The last time he came and spoke to me, he's visited more states in Malaysia than I have also, I think. So he's gone to so many hospitals in Malaysia. He's the superintendent of the China Medical University in Hsinchu. And he's a board member of ELSA. He's the associate professor of surgery in the College of Medicine at China Medical University in Taichung as well. Board member of the Asian Endoscopic Task Force, someone that I have mentored under for some time in Taiwan as well. Besides that, very good basketball player and a better golf player as well. And it gives me great pleasure to invite him to speak on lap right hemicolectomy with CME and CVL. Professor Chen, please.
Thanks, Gafoor, for your nice introduction of me, and it's pretty long. Michael, can you close out your because I can't share. Michael needs to close his.
I think he's far away, going to the toilet, perhaps.
Let's see.
How do you close it? Oh, okay, okay.
Yeah.
Is it closed?
No, you gotta. Yeah, no, it is.
It's closed, isn't it?
Yeah. So now I'm gonna share my. So before I start, I have to thanks the society, the APELS, for inviting me again, and most importantly, Michael. I mean, Gafoor, in 2005, you're not even in this field, but back then, Michael took me into this field. So I'd like to thanks Michael for your invitation again. It's been a long-term friend, and also Joel is my teacher as well. Can we see the pool, please, before I begin? Is there the pool that I have sent you? No? Yeah.
Yeah. Can you all answer this and then submit? Yeah.
Just one pool? I think I have 4, right?
Yeah, we can do it one by one.
Yeah. Okay, next. Can we show the next question?
If you ask to the expert not participating, perhaps will be more interesting, no?
I'm asking the participant.
Only participant, because I have participated and it is more.
We're asking the participant. Of course, Joel, I don't ask you this type of questions. Okay, the next question. Okay, the very last one. Okay, well, Thanks the participant for answering all the questions, and I would like to begin my talk now. And I'm going to talk on right hemicolectomy with CME and CBL. I think complete meso excision, that's including a removal of a central envelope and a central vessel's ligation and a sufficient length of bowel. I have to make a clarification of CME and CBL. Most of the time people apply this to right colectomy only, but it actually, I think this is the surgical techniques that is applicable for both left and right-sided colonic resection. But this talk, I'll focus on colon cancers and proximal T colon cancer. Well, to achieve a perfect spaceman like this is our goal doing surgery for right colectomy or a proximal T colectomy. And today I'm going to teach you how to do this type of surgery the way I do. But before going on to the procedure part, I think understanding of the mesenteric anatomy is very important. I think there are two parts of performing this surgery. I think it's the fascia fusion, which is toes fascia, and the second part is the vessel. And the vessel is complicated, especially the venous system here for right colectomy. So I'm going to break it to two parts. First of all, I like to talk on the fascia. I think everyone has an argument with is there really a mesocolon in the colon. I think thoughts have told us that they exist. So I'm not going to go through this. And this is layers of our colon's mesentery. So it has been published in 2016, showing that there are what's the perfect mesentery here. Especially on the right side here, we need to be focusing on why you're dissecting it. And there are also many spaces while you're doing it. And these spaces are avascular. So it should be very important to know the spaces of the surgical plane. And because of time factor, I'm not going to go into every one of them. And everybody and the participant can go download this paper and read it about it. I think it's a very interesting paper that tell you the spaces while you are dissecting right colectomy. So my operations starts with inferior as always, and I like to lift the right colon, such as like I always tell my fellow or my resident that I'm gonna it's like a blanket. I'm gonna like pelt it up from beneath. So this is how I stand. For me as a surgeon, I'll stand in between legs. Patient is put on a Trendelenburg position, and this is my weight of surgery is different from majority of the surgeon. I stand in the middle, and I see many surgeons stand on the right side, the left side of the patient. So then this is how I perform my right colectomy. And I have a very different trocar as well. I use one in the lower midline and the other on the right lower quadrant, right lower quadrant. And if I need it, then I'll put another assisted 5mm trocar on the right upper. So for the toes fascia, first we examine the abdomen, and then I'll begin with the retroilio dissection after I carefully check where the tumor is. So the tumor is right over here, and then I'll start it from the bottom, where you can see the iliac artery is right over there. And then you can see the duodenal suite, the second portion and third portion junction is coming in front of you. And here you can clearly see the anterior fascia, which I will dissect from. Okay. So I'll carry my dissection on over the top. The anterior fascia, you have to go superior of the duodenum instead of going underneath of duodenum. Okay. So this is how I dissect, and then for another continue video, and this surgery that I have done last week, so I have to edit by myself. So this is how I put down I tented up all the colons. I release all the attachment of colon on the right side against with the retroperitoneum. And then I would carefully dissect here, and to the end you can see the all the vessels in the back, and this is part that I will stop. And the pancreas is right over here, and I also dissect the pancreas. I'll pat the pancreas downward to explore all the duodenum, which I can remove all the colon attachment to the pancreas. And once I finish with this, then I'll flip the entire meso over, and then I'll find, as you can see here, I'll find this part is the surgical trunk, and I'll trace back to the terminal ileum, and then I'll show you how I will begin here to transect the terminal ileum first. Okay, and another case. This is another case. It's the same, and I'll show you just exactly how I explore another one. This is the easier one that you can actually see very carefully, very clearly on how it works. Underneath, you can see the urethra. The ureter is vermiculating. So I'll start it from this line here, and the above is terminal ileum. So my operation for right colectomy is quite standard. For each case, for every case, I'll go underneath first. I think it's easier for not just myself, but it's for my training to learn how to lift it up, the colon, and then finding the right plane. Instead of go to directly attack the ileocolic vessels, and then you reversely, you just go back up and down later. But for this procedure, it's always from the conduit to cephalus. Okay, so I'm not gonna. It's the same thing, so I'm not gonna show the entire video because it's the same thing like the one I showed. So the next is vessels. I think vessels is the hardest part. It's easy with why we are doing so carefully on the vessels, because we want to do mainly like we want to take the 223, 223, 213, and 203, and sometimes we want to take 214 lymph nodes, or we want to do a D3 dissection. So this is how I started, because I want to do this. And the most important part is here. We call it surgical trunk. So this is the dissection of the trunk to showing all the vessels. And the artery part is much easier. And for ileocolic artery, 100% you can see it. But for right colic artery, it's rarely about, some say it's about 13%. And middle colic artery is about 46%. I think Japanese did many of the study on this. And the vein is the part that's very interesting. It's hard, but when you learn how to dissect, I think it's easy, even though you don't know the name of the vein. I mean, just go directly from distal, from conduit to cephalic, you can find all the vein the way I do. Okay. So when look in the Venice, there's a lot of variation in the right colon, and the Japanese surgeons did a from Osaka did a study on the vein using the 3D CT. As you can see that if you look at the vein, you can see the vein 97% has this SMV. The IVC comes out from SMV, and 2.5% comes out from the gastrocolic trunk. So usually you can see the veins coming out from the SMV. As for RVC, our right colic vein, it's about 83% comes from the greater the gastrocolic trunk, and from SMV is 9.9%, and absent is 6.2%. And then for MCV, the metacolic vein that drains into SMV is about 65%, and 24% comes from drains into gastrocolic trunk, and the other goes from to JIV, the jejunal branch. So this is how I perform my surgery. I'll start it out, explore the surgical trunk by transecting the terminal ileum first. So like I said, this is a video that I done last, I think Thursday, and I don't have time to really actually put some wording on it. But you can see it clearly. This is a surgical trunk that I found. So I'm gonna go all the way up from this line. So I don't suggest that you go bite too fat, just go piece by piece. And as you follow by the surgical trunk, you can first meet the SMV, as you can see, just right in front of you, in front of me in the center part. So I usually will push the SMV to the left side of the patient. That would be safer if you push it to the left side, and then you can actually find the the iliocolic vein. So usually I look for the vein first and then artery. So how you treat the SMV, I usually pat down. I don't lift it up. If you lift it up, usually, I mean, you come to some problem with it. Oops, excuse me, it should be the next slide. Okay, now, while I explode this, here is the iliocolic artery here, vein here. Once I explode the vein, I clipped it, and then I can easily find the artery. So there are different type of artery that exists. Okay, so I usually use the ligature energy to just ligate the artery, but because I'm going to use this video for demonstrating, so I put clip. So I don't recommend, oops. Okay, once you finish, once I finish ligating the vein, then I'll come and ligate the artery first. I don't think this is a very hard surgery if you know the plane. Two of my Malaysian fellows trained with me, Wan Ching and Elaine. They both are doing very well on this surgery. And I did not know that Wan Ching was going to talk on this topic, and then I told Corita that I'm going to talk on this topic because I didn't see that anybody was to be determined. That's why I say I want to talk on this topic. instead of TATME. I think TATME, for me nowadays, we do a hybrid TATME, not TATME anymore. So this is iliac artery that I would ligate. We're going to jump a little bit. Once after you ligate, and then I cut. Okay, so it's the same. And once you ligate this artery, you just go directly up. I'm running a little bit behind, so we're gonna go faster. And then we'll carry our dissection slowly and to explode the mesocardiac artery here. So just be careful patting the tissue down and do a little bit dissecting. What type of energy doesn't matter, but it's just that you gotta do a very careful dissection while you're taking care of your surgical trunk. That's my goal of doing it. You can either use a harmonic, or you can use ligature, or you can use a thunder beat. And because I don't have thunder beat in my hospital, but in Taichung I do have thunder beat. So I like to use thunder beat while I do this type of surgery. I think a combine of both energy would be easier. Why you keep, okay, and then at the end, so I take the mesocardial vein here. So we're gonna go faster. And this is a mesocardial artery. So we take the artery. So just go carefully, you can take the vein. So all you have to do is just go straight up. Okay, straight up the trunk, and you can find all this trunk. And you can find Luke Hanley while you're doing the dissection. Okay. So at the end, I will perform a intracorporeal functional anastomosis, and then I'll transect the bowel first after ICG. And I don't have a video of I do ICG for this patient. And for the lateral side, I will do it right after I do my anastomosis. I don't take down the lateral side first. I let the tumor part hang on it, and then after anastomosis, then I'll take the lateral part at the very end, and I almost always do an intracorporeal anastomosis. Okay, and this is, in fact, now I suture with 3 Vicryl, and then I'll pull it up and I'll staple again. So I'll do a stapling to security the defect. Okay. So, while CME has been elaborated by Heuber from Germany, saying that if you do CME, you can increase your, you could decrease your local recurrent rate, and you have a better survival rate, and that's based on his 13,229 patients. 1,339 patients. But if you look at the literature of complete mesocolic excision versus non-mesocolic excision and central ligation, a paper come out from England showing that CME and compared CME and standard surgery, and it showed that CME achieved more lymph nodes. And also CME has more mesocolic plane in all patients, either on right side or left side patients. And this is how they measure their tumor and how they measure their length. And they're showing that CME removed more tissues, as well as CME are much better than non-CME patients in terms of tumor to the height, the length, and also the area removed, and also the length of a bowel and the area of mesentery that's included is better than normal non-CME patients. So they concluded that CME is much better surgery. So another study is a single institute that looking there 251 patients from 2 periods of time before 2010 and after 2010. And primary endpoint is to look at the lymph nodes and the rate of postoperative complication and mortality of CME versus non-CME. And secondary endpoint is overall survival and disease-specific survival. And this is how they do it. They do an open surgery. So they found that there are younger patients in CME group, and lymph node resected. It's in stage 3 patient is better in CME patient, and also stage 2. And total lymph node is much more retrieved when you perform a CME. So for morbidity, mortality is about the same. And the overall survival and disease-specific survival is better in CME. And disease-specific survival in stage 2 and 3 patient is better in CME. So they concluded that more lymph node harvest by performing CME. And CME is a safe procedure and can be reproducible without increase of surgical morbidity and mortality. And they think that by performing CME, it will improve overall survival and disease-specific survival. So how about laparoscopic versus open? If you look at all the study, the systemic review of the study, I found that there are 12 studies, 1 randomized trial and 11 case control trials. So these are the study that's included. And if you look at 3-year overall survival, I think it's better in the laparoscopic CME versus open CME. And also it's better in 3 years disease-free survival versus open CME. And non-significant difference in local recurrence for both group. And non-significant difference in lymph node harvest in both group. No significant difference in tumor to height distance. And laparoscopic CME has a larger resected mesocolon surfaces. And laparoscopic CME has less blood loss and less transfusion as compared to open CME. And laparoscopic has a lower postoperative morbidity. And all these results it really makes sense if you do, it does make sense if you do laparoscopic every day. And I think it had the same quality with open surgery, even better, I think, myself. So at the end, I think to perform a CME with a central vessel ligation, I think you need to understand of the anatomy and especially the fascia fusions and vessels and all the variation of the vessel. I think the principle of the dissection is most important. Either you do it open or minimum invasive surgery. I think you need to carefully dissect along the surgical trunk. And I used to be a very fast surgeon, but now I do it slowly. And I think I enjoy surgery after doing a lot of CME or D3 dissection, which both is not the same, but I think to ligate the vessel centrally is something that's, I feel like I like to do this surgery. And CME has more dissected area out, especially I think from transecting the terminal ileum first, you can achieve more surface as compared to you just attack the iliac artery. I think this is arguable, but I think it's better. And maybe randomized control trial can prove this concept, but I don't think in this era now we need to compare anything that's randomized control trial. But I think this is a very good way of doing it. And I'd like to thank Gafoor for your invitation again, and thank you very much.
Thank you, Professor Chen. Thank you so much. The only point that I disagree is the fact that you mentioned that you were fast before and you are slowing down now. So having mentored under you, I'm worried to see how you were when you were faster before. You seem quite fast now, you know. So we have a few questions, but I think we will leave it, Prof, till the end of the session. Is it okay?
Yeah.
Thank you so much. So let's move on to the following speaker, which is going to be Dr. G.V. Rao from India. Dr. G.V. Rao is actually not a stranger to a lot of Malaysian surgeons because he has personally trained and also he has come over to Malaysia many times. He is the Director and Chief of Surgical Gastroenterology, GI Oncology, Transplantation Services, and Minimally Invasive Surgery at the AIG Hospital in Hyderabad, India. The immediate past President of the International Hepatopancreaticobiliary Association of India, and he has been awarded numerous awards by from awarded the Economic Times Inspiring Doctor of India in 2018, and also the Parliamentary Gold Medal in 2015. And interestingly, I'm not sure whether I'm right, but I think AIG came out in the papers about a week ago because they came up with their own COVID antibody cocktail. If I'm not sure, they can treat COVID in 1 week. So I'm not sure whether it's the right hospital, but maybe Professor Rao, please, you can unmute and you can proceed with your talk.
Thank you so much, actually. Thank you so much for the introduction. Thank you, the entire the board of the APELS, Michael in particular, and thank Paul and Abdul for the kind introduction. Is that okay? Are you able to see the thing? Hello?
Yeah, Prof.
Is it okay?
At the moment, no. Have you shared your screen? Yeah. You share it again.
We saw the screen, but black.
Yeah, it's just black.
With the mouse moving.
1 second. I'm sorry.
So perhaps you have to choose the window of open of PowerPoint.
No, I opened it. Actually, it's not. I'm able to see the screen here, but surprisingly, can somebody go to the next talk and I'll come back again, please? I don't want to waste the time. If it is okay.
Next speaker, is it Professor?
Yeah, is it okay? Because I just checked.
No problem, no problem. Paul, could you introduce Professor Leroy? Paul, are you still here?
Hi. I think since G.V. Rao is having some problems, we'll go on to the next talk by Professor Leroy. Many of us know him. I mean, I grew up watching lots of his videos from his time in France, and of course, now he's based in Hanoi. Prof, I must apologize. My phone, when you see, just ran off, and I know you're in Hanoi now, and chairman of one of the hospitals there. And we'll be delighted to hear your talk on hybrid endoscopic laparoscopic resection of colonic polyp, something that's quite new to some of us, but definitely I'm sure you're going to share something that we'll take home today. Prof, back to you.
Many thanks. I want to share my screen. Have you? You have the screen?
Yes, yes, Prof. We can see. No problem.
Yeah, you see?
Yep, very clear.
You see my screen. Okay.
Yes.
Thank you. First, I want to thank Professor Michael Lee, to thank all the team that is working hard to organize this type of meeting, a webinar, and particularly Kadora for his help and his contact. I think she's working day and night, and she is very active to help us. And many thanks to the organizing committee from Malaysia, Dr. Mubarak and his friend, Dr. Vimal, that was a very busy guy to organize this type of meeting. I have proposed to speak of hybrid endoscopy and laparoscopic colonic resection. It's to thanks Michael Lee, because he was a guy that imagined, and we have seen in his presentation, more than 20 years, I will say during the 90s, beginning of laparoscopy, rapidly he imagined that we have to use both technology to help the surgeon, but mainly to help the patient to reduce the aggressivity of surgery. I have focused not on rectum, but only on colonic polyp, because it is a little different, because it is a TEO, TEM surgical procedure for rectum, but it is a little different. So I'm focusing on colonic polyp resection. As we have seen at the beginning with Michael Lee, we have the possibility to remove the polyp by endoluminal endoscopic approach, or using laparoscopic resection with endoscopic endoluminal assistance. Polypectomy, we know that before to developing laparoscopy, it was proposed and used a long time by gastroenterologists. Later, they proposed to do from a flat polyp, EMR, ESD, and we have a lot of technique described by Japanese school and surgeon from Asia. This is where all these technology were developed. Concerning larger polyp and larger resection, it was proposed endoscopic full thickness resection. What it is? It is a particular device to perform. This is a full thickness resection device using a big clip and firing with a thread with with a loop, a hand wheel, and a thread retriever. We use high frequency with a snare positioned around the basis of the polyp, and we remove the polyp. But it is not a polypectomy, it's a very large resection. The first step is to grasp the tissue and to lift it to a cap, and having a large resection of the colonic wall. And we remove also the serosa of the wall. But with a clip we apply, we can do a large resection as we do a resection with sutures. This is inside sutures. Other possibility, other technique proposed for developing full thickness endoscopic resection was, in case of polyp, to do first endoscopic resection with a bowel perfectly well prepared with a washout, and after using specific suture with a T-clip, and we push on one side, we push the second one on the other side, then we push to do a tightening of the two parts, and finally to close, doing inside sutures. Other technique by endoscopic, this is E-flex. This is inversion, full thickness laparoendoscopic excision. How we do? First, we have by laparoscopy to introduce T sutures with two sides and a collar, and we put at distance with endoscopic control through the colonic wall. Then we tighten, and we can complete with a suture, laparoscopic suture. So we have a big polyp, big pedicle, and to remove, we can use a snare for doing perfect resection, or a knife to do a resection in 2 times, as you see on the picture. Endoscopic resection with laparoscopic assistance. This is the beginning of how we mix. And the first that proposed this was Maurice Franklin, our regretted good friend, Maurice Franklin from San Antonio, States. And as you see, we can help the endoscopist pushing the polyp, flat polyp usually, to facilitate the endoluminal resection. And if we have a perforation, we can do a suture by laparoscopy in the same time, avoiding a large colonic resection. Other technique, the inversion full thickness laparoendoscopic excision. It's endoscopic wedge resection. It is from a low distal sigmoid. We can introduce a big stapler as hemorrhoid stapler, very large, and we introduce close and we push, we open, we have a suture fixed on the area we want to resect. We open and we push the polyp. This is, in this case, endometriotic nodule, and we push inside the stapler, and without opening the bowel, we will do a resection, and we can do a partial resection, a circular resection, removing the segment where we have the polyp, as we will see soon. And when we have resected, we have done the anastomosis in the same time and suture without opening the bowel. And it is an endoluminal wedge mechanical resection. And we will see where we have the polyp. Full notes, transanal segmental colonic resection. This is a technique I did several times, and the first live demonstration I did was around 10 years ago. It was in Singapore, and the first I did was in 2010 in Strasbourg. How we do? Exactly as transanal TME, but it's higher. In this case, it is at the colorectal junction or higher, just above. We close first the proximal rectum or the distal sigmoid, and then after we have done the localization of the polyp with a tattoo, we do the dissection, and we will divide the sigmoid just above the polyp As I said, it's not a large resection we have to do, and it's a polyp, it's a benign, it's not a cancer, so we have not to do a large resection. And this is a segmental resection, oncologic in case of early cancer, and we do the anastomosis after, doing by endoluminal approach. This is a gastric tube to evacuate the gas inside, and after we have done the anastomosis, we can open, so a low risk of bacterial contamination. Other possibility using laparoscopy, but with the assistance of the endoluminal assistance, with endoscopy. For example, we have a small flat polyp localized in this case, if I remember, on the transverse colon. So we do the endoscopic diagnosis, and outside we will see where is the polyp. And we have different possibilities. As you have seen before, we can help the endoscopists to do a small endoscopic resection and doing a suture in case of perforation. Or, as I will do in this case, I put a stitch or landmark, and this will be the possibility to have external, small, or you can do pure laparoscopy, external removal. This is the landmark, the sutures. And in this case, I will do outside small bowel resection and doing the anastomosis, removing the segment where we have the polyp. You will tell me why not doing a large colonic resection. This is a discussion we can have later, but we can do segmental resection using combined hybrid technology. Laparoscopic wedge resection, endoscopic assisted. This is what we have to do, particularly on the right colon, but we can do everywhere, but mainly right colon, because we will do large resection. First step, we clamp the distal ileum. Then we do colonic colonoscopy, and we do repair localization of the polyp. And by transillumination, we see where it is. You see, we will see what are the indications. Very thin colonic wall on the right colon. It is why the endoscopists are not don't like to do extramucosal resection, and we lift and we remove the segment under endoscopic colonic control. And we put in a bag, we remove, and we control. We control the possibility of the resection and the limit of the resection. This is a wedge resection. We can do that too to repair some hole done during endoluminal resection. We can suture, or we can do a wedge resection. What are the indications? It's necessary to have a polyp located near of the mesenteric side. The limit, it's a limit. The best is to be anterior to the colonic wall. Other limit, a lesion located near of the ileocecal junction, because it's difficult to sometimes to staples without stenosis. It's also a problem when we have extend and too large lesion with a risk of stenosis. I have some video showing we can do longitudinal, but it's not the best indication because we can have stenosis. In case of voluminous polyp, some people will say benign polyp, we are speaking. In case of voluminous polyp, we have a solution. The solution is to reduce the volume, the size of the polyp. For that, we resect step by step the head of the polyp till we reach the basis, and after we use a wedge resection. And in case of important abdominal adhesion, it can be a problem. In conclusion, thanks to Michael Lee for having opened our eyes and our mind, because using endoscopy, laparoscopy, and hybrid procedures will facilitate the treatment of some polyp, reducing, as he said, the morbidity of the patient, and the advantage of using hybrid technique is to limit the large colonic resection, not always necessary concerning the disease. It's often challenging, but there is a huge advantage for the morbidity for the patient, and keeping also maximum anatomy and function for the patient. So, as said Michael Lee, it's important to work in hybrid Endo-Lap team and OR. Thank you for your attention.
Thank you so much, Prof. Leroy, for that very interesting talk that you gave to us. There's actually a question for Paul there that maybe I want to answer now.
Yes. Finally, I've changed the title. In case of colonic polyp, what do you use? What is so full thickness? Okay. So you have to choose. It's a single choice. Or what do you propose? I'm really surprised to see wait and see, but why not? It depends of difficulty, but thermal coagulation after biopsy, I don't think it is what I will propose. Same, it's a multiple choice. We can do oncologic sigmoid resection using full transanal nodes, using laparoscopy and endoscopic hybrid technique, using only laparoscopy after tattoo, or only by laparotomy. So I have seen that it's not really good manner to ask question, but I will see the answer. Okay. The question 3, the answer 3, only by laparoscopy, I will say it's not a good answer, because we have to different possibility. It's not only, there is not only one choice. We can do open, only was error. Miss, multi-choice. What we can do, endoscopy, a wedge, by endoscopy with laparoscopic assisted, or laparoscopy with endoscopic assisted. Interesting. So by endoscopy, I will show to discuss the, sorry. Diaporama, paramètres. We choose. Okay. I will show the. I will change and show the. I stop to share. I will share a new one. You have it? So wedge, finally, there is different technique of wedge. You remember we have this technique, endoscopy. We have endoluminal with laparoscopic assistance. This is for distal sigmoid. And we have this technique. So these are three, they have different name, but three wedge resection. So the most popular technique we will use is probably, as it was in the answer, this technique, the laparoscopic with endoscopic assisted. Okay. So I have finished my lectures.
Yeah.
We can
Thank you very much.
Rao?
Sorry, Kanro?
Yes, I'm ready. I'm sorry.
Yeah, are you ready to come back?
Yes, yes, yes.
Professor Rao, can you present your topic? Right.
Is it okay now? Can you see
Yeah,
the thing?
it's clear. Please,
Thank
Prof.
you.
The floor
I'm
is yours.
extremely sorry about it, actually. Yeah. Colorectal surgery, actually, over the last few decades has evolved from open surgery to laparoscopy to robotic, and you're talking about natural orifice surgery. It's a slow progression, but I think all these have become a part and parcel of colorectal surgery now. Now, the main causes of morbidity in colorectal surgery are anastomotic leak, which seem to be related to the perfusion of the colon, the ureteric injury, which seems to be secondary to misidentification of this structure, and also nodal clearance, partly because of the access and also the areas where it is prominent, and it's likely that because of the tissue or the desmoplastic reaction, we're not able to access some of these flows. Now, the question that is repeatedly asked is, can these be avoided in colorectal surgery? The answer seems to be the use of indigocyanine green or ICG, and this seems to be playing a big role in ICG angiography, ureterography, and lymphangiography, which seems to be making big inroads into the management of colorectal surgery. I'll just show you a couple of videos as to what it is. Actually, these are not run the Now, this concept seems to be evolved from this movie called Predator 2, which came some time back, wherein this science fiction movie seems to show this concept of infrared technology, and this seems to have translated into clinical use. Now, anastomotic leaks are one of the commonest and alarming complications, constituting about 3 to 20% in the reported literature series, and the causes obviously are multifactorial in this. Now, conventionally, how do we assess the bowel perfusion? We assess by palpable pulses. This is not feasible in laparoscopy. Absence of bowel color or pulsatile bleeding from the contents. But these seem to be subjective and difficult to quantify. Now, fluorescein angiography seems to have come in a big part, which seems to confirm the anastomotic perfusion by visualizing bowel perfusion intraoperatively in real time. And we use it in a dose of 2.5 milligrams per ml ICG solution, which is injected by the anesthetist during the procedure, and the green illumination is seen within about 30 to 60 seconds. These are the two videos which are self-explanatory. I thought I'll just show you. This is how it is injected. Actually, once it is constituted, it is injected intravenously, or also I'll show you in the subsequent slide, it can also be injected intralesionally. Now, this is the video just to show you. This is one such patient who has undergone mobilization of the colon. Now we have devascularized the pathological segment, and you can see this. Now, once you inject indigo cyanine green, we'll know the perfused bowel, which very clearly demarcates and the unperfused bowel here. So you're absolutely sure that this is the phase of transection here. You can see this. We'll go distally, and you can show that that is the area of totally where it has been devascularized, so that the transection can be done. Now again, this is another same patient who's undergone a resection after completion of anastomosis. You can see this. This is the colon that is being brought, and we did a stapled anastomosis here. And then you can see the bowel is adequately perfused. Both the proximal segment and this distal segment are adequately perfused. And you're able to see the ureter here, which also fluoresces during this. And you can see this. This is a very, very good technique to show that the bowel perfusion is complete. And then you can see that at the anastomotic site, both the proximal and the distal substrate are adequately perfused. And it objectively shows that this is a good anastomosis that is done. Again, a completed anastomosis here. You can see the stapler is still inside. We injected indigo cyanine green, and you can see both the proximal and the distal substrate to be getting perfused, and this perfusion is seen as a green illuminance under infrared laparoscopy. Now, this is another patient who had an AV malformation involving the sigmoid colon. Injected this indigo cyanine green to check the extent of the lesion, and also you can see this. These are the arteriovenous malformations that are seen in this, and then subsequently this patient underwent a sigmoid resection, and then we check for the integrity of the anastomosis subsequently. So basically, we have a lot of literature to show that this indigo cyanine green is very useful. This is one such study, a randomized control study, which was done in the laparoscopic left colon resection, where the anastomosis is always below the rectosigmoid junction, and ICG showed insufficient perfusion in proximal stump, resulting in extended dissections in almost about 11%. So they were concluded that ICG is safe, it is not time consuming, can be effectively show insufficient perfusion, and helps in modifying the resection margins in these patients. Again, this Pillar 2 study, which is a multi-institutional study, which has shown that ICG is safe and feasible tool for intraoperative assessment of tissue perfusion during colorectal resection, and there were no anastomotic leaks in patients whom the anastomosis was revised based on inadequate perfusion. Again, a beautiful systematic review and a meta-analysis which shown that ICG fluorescence imaging seems to reduce anastomotic leak rates following colorectal surgery for cancer. Again, we have this meta-analysis which is published recently, which shows that this definitely reduces the leak rates, and the only limitations are the administered doses of ICG and the camera systems are not uniform in this randomized control in these studies, and randomized control studies are not included in this. Now, ICGs also seems to be useful to identify the ureters. The incidence of ureteric injury is about 0.53% in reported literature. This is basically because of failure at identification, which can lead to a conversion in 15%. Stenting can be done to identify the ureter, but it carries its own inherent risk of injury, hematuria, or urinary tract infection. A 6-French catheter is inserted into the ureteric orifice, and 25 milligram of ICG dissolved in 10 ml is injected into the ureteric orifice. This intraureteral ICG might be used to track the entire course of the ureter, even if it is in the fibrous tissue, and full thickness injuries can be recognized during immediate spillage of the dye into the peritoneal cavity. Now, lymphatic mapping and sentinel node identification is the other important point wherein ICG can be used. It has been shown that 20 to 30% of patients with N0 disease will develop distant metastasis due to missed occult tumor cells during routine histopathology or inadequate lymph node harvesting. Now, AJCC 8 considers clump of cells and cluster tumor cells as micrometastatic and defines them as early lesion, and detailed examination of all lymph nodes using serial sectioning, immunohistochemistry, or RT-PCR is desirable but time-consuming and expensive. Now, by taking serial sections of sentinel lymph node, detection probability of small metastasis is 100% in these patients. Now, near-infrared fluorescent imaging using ICG has high penetration depth and real-time optical guidance, which are important benefits in sentinel node map identification. Sensitivity and accuracy of cell procedure widely variable across the studies. Most of the studies included heterogeneous populations of patients with respect to site, stage, injection site, dye concentration, and timing. We require more studies to show the use of ICG in lymphatic mapping and sentinel node identification. Now, this is one systematic review with meta-analysis, which has shown that, which is the 8 studies including 227 patients. The pooled sensitivity is 63%, detection rate of 94%, and upstaging was seen in about 15%. Now, sometimes aberrant lymphatic drainage can be recognized. The sentinel lymph node mapping procedure can identify aberrant nodes outside the planned mesocolic resection margins. Now, this is a beautiful study which shows that in 20% of the patient, additional lymph nodes located outside the proposed resection margins were demonstrated, and in both these patients, the resections were extended. Now, this is a video which shows intralesional injection of indigo cyan green, and you can see this, it lights up very effectively. Both the lesion and also the lymph nodes seem to pick up very easily when you're injecting this indigo cyan green intralesionally. It is usually injected submucosally around the lesion to pick up this sentinel lymph node, which can be picked up during surgery. Lateral pelvic node dissection. Patients with lateral pelvic node metastasis in mid-low carcinoma rectum have worse prognosis and increased local recurrence. Lateral pelvic node dissection is a controversial procedure due to technical difficulties and complicated anatomy of the pelvic side wall. But Zoom had shown that ICG fluorescent imaging for lateral pelvic node lymph node dissection is had 2 groups, one with patients with ICG, one without ICG. And in compared with the ICG with the non-ICG group, and he's shown that the ICG group had significantly lower intraoperative blood loss and significantly larger number of harvested lymph nodes. This is the study which had shown that the blood loss is less and the harvested lymph nodes are more. Endoscopic tattooing of colorectal lesions can also be done, especially small lesions which cannot be felt on the laparoscopic side. Endoscopic tattooing has been used to guide colorectal resections. Peritumoral injection before open or minimally invasive resection is safe, feasible, and effective. Does not cause any fibrosis, inflammation, necrosis, or microabscesses compared to the India aim, and 100% detection of ICG marking within 6 days perioperatively after endoscopic tattooing, and this is the same paper which showed that endoscopic tattooing can be done, which can be picked up on laparoscopy. Now, it is also used to detect colorectal peritoneal carcinomatosis. This fluorescein imaging might facilitate intraoperative assessment of peritoneal carcinomatosis beyond the thing. And we have a beautiful study which showed that intraoperative fluorescein, the sensitivity increased from almost about 76% to almost about 97%, the positive predictive value of about 99%. Now, this is the same study which shows how the peritoneal carcinomatosis can be picked up. This is one such patient of our patient. You can see this. These are the lesions in the peritoneal nodules. Now, these pick up the ICG injected. The lesions picked up very well. And you can see this is how these targeted, these lesions which are illuminating can be picked up for target biopsy as compared to lesions which are not illuminating. These can be picked up and sent for frozen section biopsy. And it is almost always 100% confirmatory that these are metastatic deposits. Now, it is also used in guiding safe transanal DME, which is becoming more and popular. Our previous speaker has already stressed the importance of this. The fluorescence imaging with ICG has been shown to facilitate identification of transanal total mesorectal excision plane. It can potentially avoid injuries, including the urethral injuries. And intraurethral injection of ICG can help visualization of the urethra during TME. And this is the paper which shows how the urethral injury can be avoided by intraurethral injection of this. Now, this is one such patient who underwent TME, and you can see this is the distal stump. We check the perfusion of this. We injected indigocyanine. This stump is beautifully being perfused. The moment you withdraw the stroker from the stump, you can see that the entire edge beautifully fluoresces. The moment you push in the stroker, you can see it gets blanched basically because of the pressure effect. And the same thing was done after the anastomosis is done. You can see this. You can indigocyanine green is again injected to make sure that this anastomotic site is absolutely very well perfused. You can see this. Both the proximal distal stumps are very well perfused. So there are several technical factors which seem to be limiting the use of ICG. The site of tracer administration, submucosal is better than subserosal. Ex vivo versus in vivo. In vivo is better than ex vivo because of no disruption of natural lymphatic pathways. The composition, concentration, and dosages of administration. The human serum albumin increase the hydrodynamic diameter, leading to better retention of the dye. The concentration of the dye is unclear. Dose based on body weight, about 0.25 milligrams per kg body weight, is said to be better than any fixed dose. Other technical factors are optimal timing of the tracer admissions. Number of assigned lymph nodes is highest when performed 15 minutes after the tracer injection. And whenever we have this, and patients, there are several patient factors which seem to be limiting this. Higher the stage, higher false negative rates due to blockage of effective lymphatics and involvement of adjacent lymphatic drainage patterns, and high BMI and additional mesocholic adiposity. These seem to decrease the sensitivity because of decreased penetration of fluorescent light, which requires more dissection. Addition of the dye to the fat compromises the view. We require more studies to show this use of ICG in these obese patients. There will also be some literature which has come to show real-time vessel navigation which can be done. This is a procedure that is becoming more and popular. This technique can simplify vessel ligation and division for surgeons. And Rio has shown that that the time to ligate the left colic artery and the inferior mesenteric vein was significantly shorter when we use this indigocyanine fluorescence navigation. This is the same paper which shows that how it is used for navigation. So it looks like what has been a subjective evidence of checking for the bowel perfusion, it is becoming more objective, and with the introduction of artificial intelligence, I'm sure we'll see here more and more about this indigocyanine green in future. And the future of this seems to be very bright, and it is bright for molecular imaging, fluorescein guided cancer diagnosis and therapy. I'm sure we'll hear more and more of this in future. So to conclude, ICG enhanced surgery can be applied during different procedures of colorectal surgery. It offers additional information to the surgeon on anatomy, perfusion, lesion identification, and ureteric identification. It has potential benefits and is a safe procedure, and it can expand current capabilities by developments into smart and target fluorescent molecular probes and highly sensitive imaging equipment that allows recording of fluorescent signals at minute accumulations. I think ICG has become part and parcel of all laparoscopic systems, and I'm sure in the days to come we'll use more and more of this, and we'll have more objective evidence of these pathologies and also objective evidence to document this. And I'm sure in the days to come, the morbidity, mortality of colorectal surgery would certainly come down with the use of ICG. Thank you so much once again for the patient here.
Thank you, Dr. Rao. We'll move on to the next speaker and take the questions at the end. For our next speaker, we have Dr. Sangha Perumal. He's the colorectal surgeon in one of the KPJ hospitals here in Malaysia. We heard Dr. William Chen talk about right hemicolectomy with intracorporeal anastomosis. And Sangha is going to share about extracorporeal, a technique that uses with the circular staplers. So Sangha, up to you.
Yeah. Thank you, Chairman, for kind introduction, and thank you for the APELS organization for the invitation. Can you all hear me? Okay. So I wanted to present today this topic among the well-known speakers. So I'm mainly going to talk about right and left colonic functional side-to-side anastomosis using a circular stapler. Okay, we see at this anastomosis, it can be divided into end-to-end, end-to-side, and side-to-side. Can I have the first question, please? Well, it's quite interesting to know that still many people are still doing a hands-on anastomosis. I think most of us have gone away to the stapler anastomosis, and we look at this Cochrane database systemic review shows that stapler anastomosis is not superior to the hands-on anastomosis, but definitely is a shorter learning curve and is a shorten the duration of the surgery. So what is the most important for the anastomosis? As we know, this is a basic. The most two important thing is a well vascularized bowel and absence of tension. Okay, look at this picture. This is well-defined vascularity of this place, but as this becomes the end vessels, there's possibility of a microthrombosis of this part of the bowel, and which we anastomosis here always risk of bowel means anastomotic leak. And this is a common side-to-side functional anastomotic we most of us do. And see this T junction here, where is the high risk of anastomotic leak because of two reasons. One is where the double stapler technique, which is crush the tissue are there, and it's possible to have micro thrombosis over the vessel at this area. So of thinking of that, and we propose this using a circular stapler, the anastomosis are we going away from the edge of the resection margin, and it's also another advantage is that less tension over the anastomotic region. This we are demonstrating that This actually obstructed right side tumor with dilated bowels, small and large bowel. Can I have the second question, please? Yeah, we're taking right colic vessel, and we, as I think most of us, we do actually 3-clip technique to more secure. Okay, you see the specimen where the dilated colon and this is the obstructive tumor. So here you're doing the anastomosis of small bowel to the large bowel using a circular stapler. So sometimes we have this difficulty putting this anvil into the small bowel, mainly when is that bowel is going to spasm. So it's possibly we warm up that bowel, it might be dilate. Can I have the third question, please? Okay, interesting. I think it's most of us have the same practice. Okay, this is at a colonic site, which we are open up just distal to the tumor. And look at it that we are away from the edge of that resection edges, so there's well vascularized, and the color of the bowels are quite well vascularized bowel. Okay, this is doing a left hemicolectomy, the same technique. By this technique also we are avoiding this, the cross stapling of the bowel, this which is caused the crashing effect. Can I have the third, fourth question, please? This for anterior resection, we are taking more of the superior hemorrhoidal vessel, preserving the left colic vessels. And definitely we will do the mesenteric lymph node dissection for or sampling for oncology purpose. And this is that black marking is a pre-operative marking by Indian ink, which is sometimes it helps to identify the lymph node as well intraoperatively. Okay, looking at the personal experience of this technique, it's done in 2 centers in Malaysia. We have done about 16 cases of right hemicolectomy and 12 of left hemicolectomy. Average time for anastomosis are about 10 to 15 minutes. There's a complication in sense of bleeding as a nail, and as well bowel complication also is a nail. So average hospital stay is about 5 days of each patient. And we see about the literature review that this is reported in surgery today. In this technique, they reported about 3.6% of complication of bleeding at the anastomotic site by using a circular stapler. But there was no anastomotic leak reported in this paper. And this paper actually done in all the segment of the colon, right hemicolectomy, left hemicolectomy, sigmoid colectomy, and transverse colectomy. And best part, they included the patient which has obstructed lesion as well. In this paper, they only noted 0.7% of leak. Actually, it's only one patient. And then they also reported as bleeding is the main issue of this technique. So we just compare in intracorporeal and extracorporeal anastomosis. In this randomized control studies of 120 patients, noted there's a similar hospital stay in both intracorporeal and extracorporeal anastomosis. And post-operative pain, as noted, intracorporeal anastomosis less, and definitely because of the size of wound, I think definitely slightly lesser in intracorporeal anastomosis. Otherwise, that anastomotic leak and surgical site infection are the same. This paper is showing a systemic review of 25 studies of 4,450 patients, and they noted intracorporeal anastomosis have a fewer complication in sense of surgical site infection and incisional hernia. Otherwise, both groups have similar effect on ileus, bowel obstruction, bleeding, and intra-abdominal infection. So, ladies and gentlemen, in conclusion, functional site-to-site anastomosis with circular stapler is safe technique and efficient method. It's shown clinically lesser complication. However, this technique costs more in relative to other technique. So, intracorporeal anastomosis or extracorporeal anastomosis result almost the same. Thank you.
Thank you very much, Sangha, for showing your technique to us. We're going to move on to the last speaker for this evening to introduce Dr. Vimal Vasudeavan. He's presently the president of the Malaysian Laparoscopic Society, SELSMA, Malaysian Hernia Society. Someone I've known from my training days. We trained during the same batch, and he's really pushed laparoscopic surgery in Malaysia to a different level. Vimal, why don't you share with us today about ultra-low anterior resection laparoscopic? Thanks.
Thank you, Paul. I shall share the screen. Okay, can you all see my slide? Can see, okay. So first off, thanks, Paul. Yes, I would like to thank APELS for giving opportunity to Malaysia and SELSMA to co-host or collaborate for this event. I think Dr. Gafoor and Paul have done plenty of work to get this event running. Thank you also for inviting me to give a talk on ultra-low anterior resection. Before I start, I would like to pay tribute to my mentors per se, from Professor Michael Lee, William, G.V. Rao, and Professor Joel Leroy. From time to time in my initial phase of my career, you you have helped me to learn laparoscopic surgery. So my talk today is on ultra-low anterior resection. I have no conflicts of interest. In the Malaysian population, colorectal cancers, they are the second most common cancer among men and the third most among women. Of major concern is the fact that they have a major economic burden and the late stage of diagnosis. This is the Malaysian picture. Now, in terms of colorectal cancer generally and rectal cancer specifically, the development of laparoscopic staplers revolutionized the minimally invasive approach to rectal cancer. The earlier studies, I think, started somewhere in the 90s. Maurice Jacobs and Dennis Fowler, they did right and left hemicolectomy. But with the introduction of staplers, this was possible. And also development of energy devices and high definition video endoscopy systems. All these have improved tremendously the technology. The energy devices have come on by leaps and bounds. The staplers have become better in the last 20 years, I would say 20 to 30 years, yes. Reticulated even to reach deep into the pelvis. We have different sizes, 45 mm, we have 60 mm. So you need a 45 mm reticulated ones to go deep into the pelvis. Okay, high definition videos, ICGs, all these have improved dissections as well as reduces complications associated with this difficult surgery deep in the pelvis. Robotics also have their own advantages and benefits. The future may well be robotic because as I have seen when I started laparoscopy in the early 2000s, I learned from Professor Michael Lee, William, and Joel Leroy. They were the doyens of laparoscopic surgery, but a lot of them are now moving on to robotics, which shows that probably this is the way it will go. I also want to pay tribute to this WebSurge and the Asian Endosurgery Task Force, which helped me in the initial years where there were not many people training laparoscopic surgeons. So, laparoscopic ultra-low anterior resection, these have clear benefits. Okay, in the initial years, there were many studies which showed that there were equivalent benefits, early benefits of laparoscopic MIS surgery for colon and rectal cancer surgery. Okay, which includes reduced blood loss, earlier oral intake, less analgesic use, less risk of infection, and reduced length of stay. These are the benefits of laparoscopy, which are general. But when you treat cancer, the benefit is seen in the long-term outcome, the oncologic safety. So in the initial years, the benefits, long-term benefits were noted for colorectal cancers, but there was a lot of skepticism for middle to lower rectal tumors, whether the surgery was worthwhile. I'm talking about the oncologic benefits. But nowadays we know that the MIS is not inferior to open surgery in terms of a long-term outcome, in terms of recurrence and survival. They yield similar node amounts and similar CRM release. So rectum generally we know divided into three: high, middle, and low. Okay, so generally for high rectal cancer, we do a wide mesorectal excision. We transect the mesorectum about 5 cm below the tumor. But for mid and lower rectal tumors, generally the concept is to do a total mesorectal excision, which means you take out the whole mesorectum until the end. Okay. So how can we do total mesorectal excision? So generally it is preserved for mid and lower rectal tumors of the rectum. Okay, so there are three main ways these days it is being done: the traditional open surgery, laparoscopic or minimally invasive MIS surgery, and robotic. They all have their benefits. Some surgeons are comfortable doing open, or may not be may not have picked up laparoscopic, so they are quite entitled to do in the open way. Some surgeons like me, we started in the early 2000s, so we started laparoscopy. Robotic came in the last few years. Those people who have money are able to indulge in their fantasies of using robotics. Those of us who don't have that much money yet, we will plod on with our laparoscopic instruments. So when you say TME, you need to do a complete removal of the rectum and its mesentery along the anatomical and fascial plane. Okay, so my talk today will focus more on laparoscopic ultra-low anterior resection. It is a technically demanding procedure. Mainly, the common ground will be the exposure or the dissection of the left side of the colon, but the demand will come especially when you are doing a mobilization of the splenic fracture, which maybe for a high rectal or a sigmoid tumor you may not have to do, especially if they have a redundant sigmoid. If you want to do a TME, there is also a technical challenge. If you are operating on an obese patient, that's a technical challenge. If you are operating on a male patient, it's also a technical challenge. It is technically challenging when you have a male obese patient with a mid to low rectal cancer. So they all come together and make your life miserable. So much so, on the first day after surgery, when you see your patient, your patient looks better than you. You look worse off than the patient. So which means you probably did a good job. So the other thing with the laparoscopic ultra-low resection is the long learning curve. Some say 50 to 60 cases to become adept with laparoscopic ultra-low resection. The earlier studies, the color classic trials and all, mostly they thought that 20 cases were enough. That's why a lot of the outcome were not so good comparatively. But they realized that these same surgeons, when they went on doing, their results became better. So now I think the learning curve for ultra-low resection will be about 50 to 60. And the surgeons need to be constantly doing the laparoscopic colorectal or rectal cancer surgery to have good results and reduce complication risk. You can be, I'm a general surgeon, so I will term myself as a skilled surgeon. Of course, there are colorectal surgeons who are specially trained to do these procedures. Both can do this procedure as long as you have gone through the learning curve and you have all the instruments necessary to do these procedures. So before you start off, you need to know the blood supply, lymphatic drainage of the rectum, venous drainage. So basically, your rectum blood supply is from the inferior mesenteric, left colic, and sigmoid rectal, superior rectal. So in the initial years, I used to remove the IMA, flush to the aorta. Nowadays, especially for older patients with diabetes, or I know that they have atherosclerosis, then I will try to preserve the left colic. This is to make sure that in the older age, I want to make sure that I have no risk I do not compromise the vascularity of the anastomosis. So that's very important to me. Of course, the nodes around the root of the IMA, I will dissect until I expose the left colic and then transect it there. The venous return left the IMV also is ligated a bit higher near the crease ligament. The lymph nodes, of course, most of them, that's why the reason you have to take out the IMA, okay, and then the middle rectal comes from the internal iliac, and the lower rectal, they come from the internal pudendal. So that's why the mesorectum covers all these nodes. That's why you need to do a TME to get lateral, circumferential, and radial margin clearance in the rectal cancer. Okay, so this all means that you have to go in, find the right plane, anteriorly the denonvillous fascia behind the seminal vesicle and vagina in men and women, posteriorly the prevesical fascia. So this is an avascular plane. Okay, so I will demonstrate a case of this is from 2012, so a long time ago. Yeah, my system was a HD, so I hope it is not as bad as the other faculties videos. So I normally very low rectal tumors I will tattoo because I need to know where to anastomose, where to transect the distal part. Okay. As you go deeper in, a bit difficult. So positioning, of course, I'll put a nasogastric tube, central venous pressure monitoring, catheter, indwelling. I put veno pump to prevent DVT, antibiotic prophylactic. And position is a Trendelenburg head down and on the fixed on yellowfin. And the chest is secured, and the shoulders are secured too, because you need really extreme down and extreme lateral position so that the bowel will fall down and the pelvis is free for you to work. Okay, so I use 5 trocars. This is a 12 umbilicus for optics. My left hand 5, right hand 12, suprapubic 5, and one more here I will put when I go into the pelvis 5. Okay, so this is a small incision I make to bring out the specimen. So the first part is once you have positioned your small bowel, you have reduced it and freed the pelvis. You expose the promontory, the pelvis, the IMA, right up to the crease ligament. Okay. You have done this. Next step is to know you're going to do a medial to lateral dissection. I know Prof. Michael Lee, he popularized the lateral to medial because his concept was whatever you do open, you must do it laparoscopically. So I started doing this, but now for many years I have moved on to medial to lateral dissection. So you must know what structures you will encounter when you do medial to lateral dissection. Okay, so you will find the hypogastric plexus of nerves, you will find your ureter running, gonadal vessels, male, female, okay, until you see the psoas and then you go to the lateral wall. Okay, as you go towards the spleen, when you do the splenic flexure mobilization, be careful of the Gerota's fascia. If you're not careful, you may go under the kidney. Okay, so you find the Gerota's fascia and then push it down, the colon goes up. As you towards this area, you will find the pancreatic tail, and then you may expose the spleen. Okay. So, okay. So the first part of the surgery, okay, that's yeah, is incising the peritoneum from the promontory in a straight line across the IMA at the root, okay, to the to nearby the crease ligament. Okay, so you will cross the IMA to IMV. So you will expose all these structures. So first make the incision. expose the vessels until the ligament of speech. At the corner here, you may see the duodenum. You can see the duodenum there with the trees ligament. Then my assistant, who is using the instrument from the suprapubic 5 mm port, will catch the IMA and lift it up. As I work in the retroperitoneal area, then push the hypogastric nerve down, and then move, proceed from medial to lateral. This is a relatively avascular plane. It's an avascular plane because you get the occasional small vessels. Okay, so until you reach the lateral wall. Most of the time while you're doing this, you will find the ureter and the gonadal. I don't proceed to ligation of the vessel until I find the ureter. Okay, so you can see the ureter, peristalsis there, and the gonadal vessel at the other end. So this is a medial to lateral dissection of the lower part, just behind the IMA. Okay. Then you move on to the IMA dissection. So you go to the base of the IMA, dissect the lymph nodes. Okay, push it upward until you identify the left colic. This is the left colic running there. So beyond the left colic, you can put a clip. So regarding whether we use clip, in the initial phases, I used to use harmonic devices or ligashua to just put the vessel. But as I started doing more and more, I started getting more and more afraid that then I started using clips and harmonic vessels or energy devices. Then the vein, you can clip. It helps you sleep better at night. Okay, so that's the vascular pedicle. Now we are going to do the splenic flexure mobilization. So medial to lateral also. So again, you are going under the same area. You have to find your gerotas, then all pushing down only technique. Okay. So you push the gerotas down. You just have to, very minimal use of energy devices. Mostly it's a blunt dissection. So you do this until you can see the tip of the pancreatic tail. So you keep doing that, you will find the window opening up, thinning out. So you know you already reached. If you're not sure, you can flip and look at the lateral side. You will see the bruises or the peritoneum indicating you actually passed to the lateral wall. So that's another technique. Okay. So now you have mobilized the left side of the colon, brought down the splenic flexure. I still do not cut the paracolic peritoneum yet because I want it to stay attached to the lateral side. Otherwise, it will keep falling, especially redundant sigmoids, and make your dissection difficult in the pelvis. So now we have to understand the concept of mesorectum. These are the fascial planes. It was introduced by this person, R.J. Hill, So it is also known as the holy plane of heel. It's the presacral fascia in front of that sacrum. Okay, you don't want to go behind that because of the sacral plexuses may bleed torrentially. And then anteriorly, as you go down the bladder, and then in male, you'll get a seminal vesicle. So this is the denonvillous fascia. Okay, then you will spare the seminal vesicle, they will go anteriorly. Okay, if you don't see them, it's better. And then in women, you will find the vagina along here. Okay, so that's why this becomes challenging. As you go, it's a bulky tumor, you have to take out the mesorectum. Sometimes your view is reduced. Okay, so like I said earlier, it's between Waldeye's fascia and the denonvillous fascia. So to help me retract, I normally make a small window and put a tape high up in near the rectum. Near sigmoid, yeah, I tie it so that my assistant can use this to pull. Because I don't have the advantage of like most of you guys. I operate with my nurses, so I need them to be safe. I cannot give them the hold of the bowel and expect them to dissect. So first part is go posterior and bring the rectum out of its sacral curvature. So when you do this, this is operating in the presacral fascia. Make sure you follow the ureter until it turns down, turns anteriorly to enters towards the bladder. Okay, so you make sure you don't hurt the ureter. Okay, stay in the presacral fascia. Do the posterior dissection first until you reach the levatus. Okay, then you will find rectal wings on both sides. Then you release the lateral one. So this place is very avascular. Once you have done that, then you go to the lateral. This is called the rectal wing, the lateral dissection. And then you peritonealize the retroperitoneal rectum. Okay, so now you are entering behind the denonvillous fascia. So this is where the thing. So finally, when I've done all that I can, now I cut the lateral peritoneum, which holds the left side colon. So until the spleen, just to bring it down. If any small strands, you can release them as you go along. See the bruise there? It indicates you already dissected until there. I'm sorry if the video is not as clear as the other videos. This is from 2012. Okay, so if you have done most of your dissection, so this just to connect everything. So that is where I've done before. So I just need to connect it. So I'll forward at this point in time. So that's a dissection in the intravalgus fascia. So your assistant actually pushes to the opposite direction. This is to have the concept of traction and counter traction. It's very important, especially operating here. So you can see the seminal vesicle there, the right one. So similarly, go and complete on the left side. So I can begin to see the tattooing which I have done. And you can see the sphincter fibers also. If you are not putting tattoo, because it is lower down, you can use the assistant to put your finger inside and to guide. Okay, so the mesorectal is almost complete, so you can almost see the rectum on all areas. Okay. So now we go on to the stapling. Then how I do the anastomosis and also do the leak test, also called as the Cousy test. So stapler needs to be reticulated, and as you go deeper, try not to use the 60 mm staplers. You need the 45. You may need to make more than one firing. The reason for that is you have done so much of dissection. It's very frustrating to not be able to pass the thing, the stapler through. See my finger at the distal part to check whether I've got enough clearance. So this is a tumor at 5 cm. So I can feel about 2 cm of my finger inside, and then the stapler. So I know I got about at least about 2 to 3 cm margin clearance. Okay. If you have difficulty, you can use a fist at the anus and push up. Your assistant can do that. Okay. So usually, if you have to use multiple staplers, the risk of leakage, I think, will be a bit more. So always cover with the stoma. Next. So next phase is actually to exteriorize, just like how Dr. Shankar showed you just now. Exteriorize, do the proximal excision, insert the anvil, and then push back in and cover. And then I will do the circular stapling from below. So often when I'm doing this, my right hand is in the perineum, my left hand is on top. So I have to keep changing my gloves. My nurse keeps changing my gloves. So I have to move both ways to make sure that I don't break sterility. Okay, so that's the anastomosis. Bowel wall looks healthy. Of course, back then I was not doing ICG. Recently, I started doing them. So this one is basically I'm doing a jacuzzi test to look for leak. I fill up water, saline, and then clamp the proximal part and then flush air and see. This one is the segment of bowel I'm going to bring up as an endostomy and then putting a drain. So that's my technique of laparoscopic ultra low anterior resection. Okay, so that's my approach. Of course, as time went on, different surgeons, master surgeons came up with different techniques. The coloanal anastomosis, okay, the robotic rectal resections, especially for beneficial for very obese male because of the ability to see deep in the pelvis, more resection, ability for the surgeon to sit down, rest and do the, relax and do the procedure, okay. And then the transanal total mesorectal excision, which that's probably left to the hands of the masters. Time will tell whether all these are as good as options. So in conclusion, I would say laparoscopic surgery for mid to lower rectal cancers of the rectum requiring TME, they are safe based on current evidence in the hands of the expert surgeon, those who have undergone the long and steep learning curve. Okay, they are not easy to perform, but they can be, if you have considered all things, they can be considered the preferred approach. Thank you. Maybe I'll have my polling questions now. I will stop sharing. Okay, so so TME is done for rectal tumor of can we have the, it's too difficult, sorry. Yeah, so last question, get it. Next. Polling is false regarding holy plane of heel, except okay. Yeah, that's it. Okay, so it's an avascular plane. It's not a vascular plane. Okay, so anyway, it's bounded by Waldeus and Vimal fascia. Next. This is a bit more straightforward. Okay, can we have the answers, please? Responses. Yeah, great. So thank you, Paul. Thank you, Gafoor. Thank you, APELS. Thank you, Kadora. I shall stop sharing the screen now.
Right. Thanks, boss. Thank you so much. So we have quite a few questions, but we are running out of time. So we will go through as soon as, as fast as we can. I think we have one for Prof. Leroy, interesting one. Dear Prof, is your technique similar for ultra low? If not, what do you do differently?
You ask a question to me from
Yes.
for TME, is it
Yes.
right?
Yes, yes.
For ultra low, I will do now coloanal anastomosis, finishing my technique by transanal way.
Okay. Okay.
Why? Because I will do side to hand. It's equivalent of with a reservoir, side to hand anastomosis, so better for the quality of the vascularization, as we have seen when we were speaking of side to hand anastomosis for ileocolic or colocolic. This is better for the quality of the vascularization. And it seems easier and less risk of weakness and leak when we do like this than ultra-low rectal, particularly in obese patients.
Thank you, Prof. I think Professor William has answered most of his questions online. He's a smart man. He's used to doing this. I want to ask you, Prof, if you are doing the right hemicolectomy with the technique that you mentioned, especially following the vessel all the way up, where is the learning curve the most steep for the trainees that you realize when you train them, actually following this technique?
Well, I think the most difficult is to find the SMV at the right place.
Right.
So we transect the ball. So we split the ball into half. The other side is mobile. The other side is the terminal ileum. So by traction, the terminal ileum, then you can easily find the SMV. I think two of your Malaysian surgeons who came over for a year, they are superb doing right colectomy.
Right. I agree with you. That is very challenging actually, to find it the right plane to go up.
Yeah.
Once you get it,
once you find a plane, it's easy.
Yeah, it's like a roadmap. Paul, any questions?
Yeah, there was one question actually about the ICG to GV Rao, but I think because he's not there, maybe William can try to answer this. This use of ICG, would it be medico-legally needed in the future if it's going to help decrease leak rates?
That's a very good question. We use ICG mainly to tell the patient that the blood supply was okay during the surgery, but medically, legally needed, I'm not sure, but for protecting ourselves, like you tell the patient it was the blood supply is well supply, and they will understand once it's leak, it's not associated with technical problem.
All right.
So we use it as always.
Michael, you want to say something?
Oh no, I'm just trying to what a magnificent output from all our faculties. I hope the audience really enjoyed today's session. I listened to the whole affair, and I think everybody put in the effort to deliver a very, very good presentation.
Yeah.
So I think we can conclude, Paul, Prof. Michael, because it's already past 7:30. It's a weekend night and we have things to do. And
hey, it's MCO. What do you have to do?
I will find something to do.
Have a drink.
That's a lockdown, lockdown drink.
Thank you.
Lockdown drink.
I think before we end again from Malaysia, thank you so much for our invited faculty internationally, Professor Leroy, Professor Ken, GV Rao, and Professor Lee. And thank you for our local faculty as well, Mr. Vimal and Mr. Sankar. And thank you, Paul, for joining me. And I think maybe I'll invite Professor Lee to give some final words before we end this session.
No, well, I thought I already gave it.
Okay. Okay, great.
Great.
Okay.
I think we should go to dinner.
All right. Thank you, everyone. Have a good night.
Thank you,
Thank you so
Gafoor.
much again.
Great
Bye-bye.
job.
Thank you, everyone.
Bye.
Bye-bye.